Doktor.
Yep. Yes.
Yang lagi seorang tu ada internet connection. Dia still tengah try nak masuk. So I think we can proceed.
Siapa yang present dulu? Siapa dulu?
Alia.
Alia start lah.
Alright, okay. Thank you, Doktor.
Alia, Alia. Tak start lagi.
Dah ada, Doktor.
Zain, dah boleh start dah.
Okay, go Fatul.
Okay, so today we are going to talk about the fourth topic. I am Fatul Hakim. I will be presenting about the overview of the children with special needs. Okay, next. So this is my outline. First, I will present about the introduction. What is children with special needs? And the epidemiology and the type of children with special needs. Number 4 is the evaluation of children with special needs. 5, how we are going to manage, or what is our goal of management generally. And then 6, how we are going to protect or help the children with disabilities in Malaysia. Next. So, what is a person with special needs? It is a person with disability, include those who have long-term physical, mental, intellectual, or sensory impairment, which it hinder their full and effective participation in society on an equal basis with others. So next. So globally, there are 50% of world population live with some form of disability. So this also includes Malaysia. So next. In Malaysia, based on UNICEF 2040, there is 1.5% of the total Malaysian population are estimated to be living with disability. So disability people in Malaysia was almost 4,000 in 2011, and there is increase in 2012. There is 450,000 in 2012. So there is an increase in number based on Department of Social Welfare. However, according to the Ministry of Health, there is only 22,000 child with special needs registered from 2004 to 2012. So we can see here and say here based on the statistics that there are many children with special needs that have not been registered. Next. So what is the children with special needs? What are the types? So first is visual. Second is hearing, those who have hearing impairment. Third, learning disability. 4, speech disability. 5, there is multiple disability. What is meant by multiple? That maybe the person have more than 1, 2 or more disabilities. 6, mental disability, and 7, physical disability. This type of children with special needs is defined by Ministry of Women, Family and Community Development. Next. First, we go hearing impairment. hearing impairment is unable to hear clearly in both ears without hearing aid or unable to hear at all even with hearing aids. So we have two types of hearing impairment, which is sensory neural and conductive hearing loss. Sensory neural, as we know, is caused by a lesion in cochlea or auditory nerve and is usually present at birth. However, conductive hearing loss, it is arise from abnormalities of ear canal or middle ear. So sensory neural is present at birth. So basically, they have severe impairment of hearing loss or profound hearing loss. As compared to conductive hearing loss, they are acquired. Most commonly is otitis media with effusion. So there is mild to moderate hearing loss. So for sensory neural, we can manage them by amplification or cochlear implant if necessary. For the conductive, we can give conservative with antibiotic, or if there is effusion, we can insert the grommet. Okay. As you can see at the side, there is severity table. So the mild hearing loss for child is 15 to 29. However, for adult is 20 to 29 decibel. The moderate, severe, and profound is similar to both child and adult. Next. Next is visual impairment. So there is blind in both eyes or blind in one eye or limited vision in both eyes or any other permanent visual disturbance. There is the definition for low vision is worse than 6/18 but equal to or better than 360. So if that less than 360, we can say that there is counting finger hand movement. So that is lower than 3/60. So blindness is less than 3/60 or visual field less than 10 degrees from fixation. So how we want to know that this infant has visual impairment? So there is loss of red reflex from a cataract. As you know, red reflex is from the light reflection from the retina. So cataract is there is opacity in the lens or there is a white reflex in the pupil due to retinoblastoma, cataract, or retinopathy of prematurity. Not smiling responsively by 6 weeks poster, and lack of eye contact with parent, visual inattention, random eye movement, nystagmus squint or strabismus, which mean by there is misalignment of visual axis and there is photophobia. What is the cause of the visual impairment in children? Next, can divide it into three: genetic, antenatal, and postnatal. Genetic is cataract, albinism, or retinoblastoma. Antenatal and perinatal, there is congenital infection, ROP, HIE. HIE is hypoxic ischemic encephalopathy, and there is cerebral abnormality. Postnatal is due to trauma or infection. There is Snellen chart there. I think you guys are familiar with it. And below the Snellen chart, there is the presentation of normal reflex and absence of red reflex, and there is red reflex abnormal, which is white reflex, maybe due to the cataract or retinoblastoma. Next. So speech and language impairment is defined as inability to speak that impairs proper communication and cannot be understood by those who interact with the person. So it can be either receptive or expressive. So speech and language delay may be due to hearing loss. Global developmental delay. Global developmental delay is defined as two or more delay in domain, either fine motor, gross motor, social, or speech. Okay. And there is difficulty in speech production due to anatomical deficit, and there is environmental deprivation. So speech and language disorder include disorder of language comprehension, which is there is difficulty understanding or processing the language. And there is language expression, which is the inability or difficulty producing the speech. And there is phonation and speech production, such as stammering, which is disfluency. So, and dysarthria or verbal dysprasia. And there is pragmatic, different between sentence, the meaning and the speaker meaning, which is not aligned, construction of the sentence, semantic and grammar, and there is social or communication skill problem, such as in autistic spectrum disorder. Next. Physical disability is defined as permanent inability of the part of the body caused by loss or absence or inability that can affect their function in fully carrying out basic activity, such as limb defect, either is congenital or acquired, including loss of tongue is regarded as physical disability, and there is spinal cord injury, stroke, traumatic brain injury, dwarfism. Dwarfism is defined as less than 142 centimeter for men and 138 for women. And the most common one for physical disability is cerebral palsy. As you need to note here, physical disability carry out two meaning, which is there is loss of a part of body, one, and there is that disability can affect their function. So if there is loss of finger, additional finger, or earlobe fully formed, not fully formed, not well developed, it's not um, being categorized into this category, which is physical disability. Okay. That learning difficulties is intellectual capabilities that do not conform with the biological age. So those that fall within this category include that late global development, Down syndrome, there is intellectual disability or learning disability in autism, ADHD, and there is specific learning difficulties such as dyslexia, dyscalculia, dysgraphia. Next, mental disability, state of severe mental illness that cause an inability to function in person, whether partly or fully. So this is the causes the disease that may include in the mental disabilities such as organic mental disorders, schizo, paranoid, mood disorder, psychotic disorder. But to include this category, you must have like two criteria. First, the person must undergo psychiatric treatment for at least 2 years. And second, there is evaluation of the psychiatrist whether the disease affect the daily function of the person or not. Okay, next. So there is evaluation of children with special needs. So we have to assess medically from the motor assessment, psychologically, and there is education assessment, and last but not least is social assessment. Next. First, we go for medical assessment. We have to know the cause of the developmental dysfunction. So we have identify and interpret the medical condition. How we want to do that? We can get the history, thorough history and physical examination. Second is motor assessment. So we can do the neurological examination, and we evaluate them by age appropriate adaptive functional evaluation by specialty and therapies. Next. Third is psychological assessment. We want to test the cognitive ability, so there is evaluation of personal and emotional well-being, and by doing that we can do the IQ and mental age score. Mm. Educational assessment, we evaluate areas of specific strength and weakness in reading, spelling, writing, especially and mathematical skills, and then we develop individualized educational plan. social assessment, we go to home visit. Home visit provide more comprehensive evaluation, and we just suggest that additional adaptive equipment or renovation. So we can also refer local protection agency for suspected neglect or abuse. Um, in city that we can prescribe the wheelchair, this special wheelchair for the cerebral palsy children. Okay. Goal of management is to maximize the child's potential for productive adult function by first treating the primary diagnosis. So you have to know what is the cause of disability in the children. Second, helping the patient and family deal with stress and secondary impairment. Okay, next. So children with disability in Malaysia. Um, so we got many way not many uh, suggestions to protect the children with disability in Malaysia. So first is early detection and intervention. Second, healthcare program. Third, education. Fourth, protection program. Fifth, protection act. Okay. Next. Okay, first we go to early detection and intervention. So Ministry of Health have a health record for baby and child 0 to 6 years. So we can detect early early detection of children with disability. And the Ministry of Education have this program named Literacy and Numeracy Screening. As you can see in the picture below, at the left, there is a skill that need the children to pick up. The skill is able to read, write, and understand. So there is 3 years, uh, first 3 years that these children needs to pick up, and if they don't fully fulfill the criteria, so they will be fitted in. So they will detect this child as the children with disability, so that we might intervene earlier. So second is healthcare program. There is many programs that have been um, hold for these children. So there is government hospital and health center. We train the occupational therapists, physiotherapy, and social workers. There is community-based rehab center, which is one-stop center intended to provide diagnosis, rehab treatment, special education, and vocal training. And then there is health screening program yearly, which is they have the yearly health screening for students in year 1 and 6 in primary school and form 3 in secondary school. Okay, next is education. So for children with disability in Malaysia, there are special education school. Special education school is the specific school for children with disability. Okay. Special education integrated program is the specific classes in mainstream schools dedicated to children with special needs. So there is also private sector education center, they being had by NGO. So they do the homeschools and private tutor. Okay, so there is also a protection program, which is MOE, Ministry of Education, indicate monthly cash allowance of RM 150 in primary and secondary school of primary and secondary national school. Okay, there is also Taman Sinar Harapan that is provide resident care and rehabilitation. Next, okay. There is also protection act. Actually, in Malaysia, there is many act that protect them. Okay, there is include the basic necessity and their right to live as a normal person in terms of job, education, healthcare. But it is the one that can conclude uh, all, not all, but that conclude that we want to take care of them. With the Child Act cover 12 category of children in need of protection, include case of physical, sexual, mental, and emotional abuse, and ill-treatment, neglect, and abandonment. It allows authority to take over temporary custody or remove to a place of safety a child deemed to be. Okay. And then the second one is remove a child to a place of refugee and rehab for a child deemed to be in need of protection and rehabilitation. Yeah, that's all my part. Thank you.
Any questions or not? Any questions not? If no questions, we just continue.
No, I guess.
No,
Yeah,
no.
because it's mainly never mind. Because it's mainly this whole topic is mainly about social issues. I tak ada third year WhatsApp. Okay. Let's continue mental retardation. But you guys know, right? Nowadays you don't use this term. This term is no longer used because it's
I will explain that.
yeah, because it's of yeah, you were gonna explain after this, right? Ali, Isa.
Yeah. Yeah.
Okay.
All right. So okay. I'll be. My name is Ali Muhammad Isa. I'll be presenting about the topic I was given is the mental retardation. Okay. So all right. Can you hear me? All right. Okay. So the word this term mental retardation is introduced in DSM-2, and however, it's a term that is no longer used in internationally right now, as changes have been made. The intellectual this is the is a definition is neurodevelopmental disorder that begins in childhood and intelligence and adaptive skills, affecting at least one of the three adaptive domain: conceptual, social, practical. And the onset of deficit during developmental period is before 18 years of age. So there are three main points. So the limitation is both intelligence and adaptive. And then there's adaptive at the three adaptive domain: conceptual, social, practical, and it has to be diagnosed usually during the childhood. Okay, next. Ali, sorry, can you explain again about why mental retardation is not used, and what are other terms that are being used? Because just now you are stuttering. Oh, okay. So mental retardation is initially introduced in DSM-2. So, however, this term is no longer used currently internationally. So the word mental retardation has been changed to intellectual disability or intellectual developmental disorder in DSM-5. That's all. So okay. So next slide. All right. So diagnosis of intellectual disability in DSM-5 requires the satisfaction of the three criteria. So the three criteria are the intellectual functioning, which covers the reasoning, problem solving, planning, abstract thinking, judgment, academic learning, and is confirmed by clinical evaluation and individualized standard IQ test. So from here, we can see that it means that there's a limitation in the general mental capacity or intelligence difficulties. All right, so deficit in adaptive functioning, it is defined as significantly hamper conforming to developmental and social cultural standards for individuals, independence and ability to meet the social responsibility. So here it means that it determines how well they're able to participate in multiple settings, in case or in the setting of school, the community, or in the house itself. So how much support they also require to be able to participate. So the last criteria is the onset of this deficit. It occurs during this childhood, usually before below 18 years old. So next. All right. So the first criteria, intellectual functioning. So it's one of the required component of diagnosis of intellectual of ID. So the criteria to diagnose is it has to be 2 standard deviation or more below the mean IQ, the mean, which is the IQ score usually less than 70 or roughly below the 3rd percentile, and this indicate a significant intellectual impairment. So in DSM-5, however, in DSM-5, IQ score has been de-emphasized, and so what that means is that those who have an IQ score of less than 70, however, they don't have that significant adaptive impairment, which I'll explain later, will not be considered to have intellectual disability. Intellectual, they will not have ID. So, all right. So the one of the most commonly used standardized test is a WECHSLER scale, which I will explain later. Next slide. All right. So adaptive functioning, we divide, as I mentioned just now, we divide adaptive functioning into 3: conceptual, social, and practical. And it's a required component also of the diagnosis of ID. So in conceptual, we have 3: literacy, mathematics, and also abstract or theoretical. So we have to see if how well he's able to speak, read, or write, how well he is able to do mathematical problems, and also how well he's able to judge based on the situation. So social domain, so we have to look at how well they communicate, how well they the empathy, and also the social problem solving. So lastly is the practical domain, how well they do in their daily living activities, like whether they're able to eat independently, dress, or go to the toilet, or do they need actually any support? How extensive is the support is required? All right, so the making a diagnosis of this of ID requires impaired functioning of at least one of the following of these 3 domains. So you just need one of these 3 domains to require the diagnosis of ID. All right, so next slide. All right, so here we see the severity of the adaptive skill domain. So the severity is based on the 2 categories. Either we follow DSM-5 or AAIDD. So they have different name for the category. So the main point here is that, so on conceptual, conceptual is based on how well they're able to do academically, like for example, or how well they're able to manage their money. So the severe it is, the more support they will require from their own caretakers or their own guardian. For social, so in mild, we see that they're able to interact with other people, but their judgment or this social skill is very immature for their age compared to their peers. And the more severe it is, the less sentence structure they will be able to use. So maybe in moderate, they will be able to use very simple sentences. And while severe, they only can use very basic single words. And while severe, the way they cannot communicate maybe by words, but they usually express themselves non-verbally. So lastly, practical. Practical is on how well they're able to live their daily life. So for mild, they're able to, usually can go to work by themselves, but they might need some parts. They might require some support, especially very complex types like doing healthcare, doing finance, or raising a family. That complex situation. And the more severe it goes, the more support they require. Like maybe like moderate, they can still go to work, but they need a working environment that with the support of other people also. And while severe, they only able to do their daily activity, daily living of activities, while the profound will not be able to do anything by themselves and require very extensive support. All right, next. So these are the assessment tools for intellectual function and adaptive function. So in intellectual function, there are two most common are the Bailey scales of infant development. Usually this is used for those from 1 to 42 months. And the most common is WECHSLER, preschool and primary scale of intelligence, where it is used for children at the age of 2 years, 6 months to 7-year-olds. So this is based and adaptive function is the most common use is the VINELAND adaptive behavior scale. This assessment tool I'll explain later. So this instrument use should be appropriate. The type of instrument should be used appropriately based on the level of functioning or their age, based on their age, language, and how easily these instruments are available. Okay, next. So this is for intellectual function, the WECHSLER preschool and primary scale of intelligence. This is a very commonly used for children aged 2 to 7 years old. So from the left, you can see a picture of what they're being assessed on. And on the right is usually the results. So as you can see, the IQ score below 70 is usually already considered as very severely impaired. So next, VINELAND adaptive behavior scale. So the left picture is the domain that been assessed. So there are communication, daily living skills, socialization, motor skills, maladaptive behavior. So this VINELAND is a standardized measure of adaptive behavior, how they function in their everyday life. So on the right side is an example of a report. This is just an example of a child, how from here you can see the communication skill is low, social daily living skill moderate low. So this is just an example. Okay, next. So etiology. So when we evaluate for a cause, we usually divide the etiology into 3: prenatal, perinatal, and postnatal. So the main point here is that among the known causes of ID, the major causes are the genetic abnormalities. The most common, especially, is the chromosomal disorder, like your Down syndrome, Fragile X syndrome, and then followed by metabolic disorders, which also can cause ID. All right, so and a minority of cases also can have environmental causes like your tetrodotoxin, toxin, infection, trauma, and birth asphyxia. Okay, okay, next. So this is the examples. The example of the main causes of ID. The most common is Down syndrome. So they're the most common known genetic cause of ID, where they are characterized by, as you can see, the dysmorphic features like epicanthal folds, small ears, flat occiput, and they also have congenital malformations like cardiac defect, and and also they might also present with other health problems and medical conditions. All right, so the second most common cause of ID is a X-linked single gene disorder called Fragile X syndrome. So in Fragile X syndrome, they are characterized by moderate to severe mental retardation. They also have some distinct facial features, as you can see that they have a long face. You can see that they have a long face and they have a large ears, and they also have a prominent jaw. And it's more, Fragile X syndrome is more common among male, about twice compared to the female, as there's a variability of expression in females that carries the full mutation. All right, so the third here is phenylketonuria. So this is the most common among the error in metabolism. So the mode of inheritance for this PKU, phenylketonuria, is autosomal recessive. So what happens is that there's a toxic level of phenylalanine due to the mutation in the gene encoding the phenylalanine hydroxylase. So what the main hallmark of this disease is like irreversible intellectual disability, seizures or convulsions, behavioral abnormalities, microcephaly. There's also any skin disease and body odor. So these are the products not given to phenylketonuria PKU. Meat, dairy products, dry bean, nuts, and eggs. All right, next. So these are the risk factors for having child with ID. So the most common are the low level of maternal education, advanced maternal age, poverty. Some studies have also shown that advanced paternal age, low birth weight infants, and multiple births also can lead to high risk of children with ID. So the low level of maternal education is the strongest predictor of children with mild ID. So those mothers who have education like during primary school will likely have like 7 times greater than those with.
Guys, wait. Let me. You guys know how risk factors and causes are two different things, right? So when you have risk factors, it basically just means if you have this number of factors, then the chance of getting a certain condition is higher, right? It's not a cause. You get what I mean, right? So if the mother is of lower maternal, if the mother is not well educated, if the mother is very, very old, the possibility of the child being a child of low intellect will be higher. Because if you think of it in this way, if the mother is very, very old, what are some of the risks? How are some of the babies that are born to mothers of advanced maternal age? The risk of getting a child with trisomy 21 is higher, isn't it? Right? So I am using the phone, so I cannot see your faces. So I don't know whether you're nodding or you're gilinging kepala. Okay, anyway, so if the mother is old, there's a higher risk of getting a child with Down syndrome. Therefore, a child with Down syndrome is obviously a child with a intellectual disability. Because the way you are presenting right now, it makes it seem as if you are saying that these are the causes. These are not the causes. These are just risk factors. If the mother is poorly educated, if the mother is very, very old, if the mother is very poor, then the possibility of the child being of low intellect is higher. That's all, right? if you have a very, very old father. Why? Because when you have an older father, the risk of getting things like Edward syndrome is higher. So those children with Edward syndrome, obviously intellectually disabled, right? If this child had a history of being a low birth weight infant, so all this, you know, low birth weight infants, if it's due to placental insufficiency, right? Or low birth weight as in prematurity. These children are the children that you have to monitor for developmental problems anyway, true not? Right? If you have children, if these kids were twins or triplets or quadruplets or septuplets, also risk of being delivered earlier prematurely, or risk of twin-to-twin transfusion, also higher, right? So therefore, these type of children may have intellectual disability. You guys have to really make a distinction between having risk factors and causative causes. It's two totally different things, okay? So don't mix them both up. Understand not? You have to say yes or no because I'm using the phone right now. I cannot see your faces. You understand not? Because the presenter, siapa yang present tadi? Sorry, nama lu dah lupa.
My name is Ali.
Huh? Ali kan?
Ali.
Ali, sebab cara Ali explain tadi tu macam it's like you are saying these are the causes, these are not the causes, these are basically just risk factors. Okay?
All right.
Understand not? Right? It's two distinct things. Okay? And then after this, kat chat tu tak apalah, kemudian lah. Ali sama dulu.
All right. Okay, so next slide. So history taking. So in history taking, the history physical examination, or you can identify the etiology of ID around 70 to 34% of the cases. So first, a comprehensive patient and family history of intellectual disabilities, where as usually a 3-generation family history should be performed, and to assess the neurodevelopmental and genetic disorders. All right, and we had to look at previous gynecological and obstetric history, where we look for any infertility or fetal loss or any. Yes, okay. And lastly is assessment of maternal health status during the pregnancy with the involved child. So we ask, especially the obstetric, during the obstetric history, whether patient has been exposed to any medication, any alcohol intake in the pregnancy, any other environmental exposures, and then we see any signs of infection. Sorry. Okay, so next slide. We also ask for the history of the child. So we look at the birth history. How was the length of the pregnancy? Any premature onset of the labor or rupture of the membrane? The duration and cause of labor, and the type of delivery. So because these all increase the risk of complications of the child, which can then lead to ID. And second is APGAR, which I'll explain in detail later, where okay, the third is the parents should also be asked if the newborn has any illness or any problems with feeding or sleeping difficulty, and whether it's able to do any problem with feeding, like sucking or swallowing. And we also look at the general disposition if the child or infant is always been crying non-stop. All right, so next, the APGAR score. So next, APGAR is the mnemonic of appearance, pulse, grimace, activity, and respiration. So these are the points we have to look how based on the condition of the child. All right, so next, the relevant history by age. So the anomalies and physical features that are discussed. Okay, so newborn, we look at the dysmorphic features like your the birth pair, like any microsomia, microencephaly, any like any cleft leaf, like as mentioned also just now, any dysmorphic features. And then in early infancy, look at the infant if he or she is not able to interact with the environment, or any concern about vision and hearing, like maybe the infant is not able to notice the parents at all, not responsive to any sounds. So in later infancy, there will be also gross motor delay, where during this this age, 6 to 18 months, at 6 months, the infant should be able to pull, to sit, lift the head of the couch, and then by 18 months, already should be able to walk well and run, and also to hold the door while walking. So we should look at those. So for toddlers, we try to look at the language, especially. So by the age of 2 years, the child should already have able to say 50 words already, ideally, and also able to form 2 to 3 word phrases. And by 3 years, should be able to introduce him or herself with the full name, with the gender and age. So, and then later, in age, preschool and school age, we try to maybe assess how well they do with their peers, how were they able to play, or are they just prefer to be alone, how well they do academically. All right, so next. So for physical examination, we measure the standard growth parameters, the height, weight, head circumference, and if the child is already known to have any syndrome, there will be a syndrome specific growth chart. And then we also look for these points, microcephaly or macrocephaly. As in macrocephaly, they will have, usually because due to hydrocephalus or maybe due to any primary skeletal cranial dysplasia like the osteogenesis imperfecta or any osteoporosis or rickets. All right, so dysmorphic features, I'll explain a bit more later. Skin examination, so it might be a neurocutaneous manifestation like neurofibromatosis. We also examine the ENT, like including hearing assessment, so which might explain why the child is not responsive. And we can also do eye examination and vision. And lastly, to assess the heart, lung, and abdomen, genitourinary system, as they usually coexist with other syndrome, like especially Down syndrome. All right, so next. Okay, these are the dysmorphic features that we can look. These are some of the common dysmorphic features. So like the flat nasal bridge is usually can be a sign of Down syndrome, Fragile X syndrome, Klinefelter, Bartola-Scott syndrome. Small palpebral fissure can also be seen in fetal alcohol syndrome, Williams syndrome. So these are the common dysmorphic features we can find. All right, next. So investigation. So our goals is to identify the particular disorder so that we can provide more information to the family. So however, the approach may differ if it's if there's associated autism, cerebral palsy, or epilepsy. So genetic studies, we can identify the chromosomal abnormalities, single gene disorders, and mitochondrial disorders. And then children in chromosomal testing. We can use the chromosomal microarray analysis. That's the most common test we use to identify the causes. And then, all right, so metabolic, we also can, for metabolic, we can also, usually we try to look for the concentration of plasma amino acids, the urine, serum ammonia, and lactate. We also can look for electrolytes to detect any acidosis. And neuroimaging and electroencephalography usually done if there's a history of any seizures or any degenerative neurological symptoms. So there's some of the findings we can find, like CNS malformation, white matter abnormalities. So next. So as I already mentioned just now, so the indication for genetic testing, if the patient if the parents are of a consanguineous marriage, the mother has any history of multiple miscarriage, the child has any dysmorphic features, whether the child has any failure to thrive or stature abnormality, and lastly, abnormal tone. Okay, this I already mentioned. So next. So for the management, so some of the early application of to do early intervention the aim is to optimize the functioning and the progress of infant and children with ID. So therefore, the goal has to be appropriate and achievable. So some of the services we provide are the speech and language and occupational therapy, and physical therapy, rehabilitation, family counseling and support, behavioral intervention, and educational assistance. As the main here is to strengthen the areas of reduced function, to provide any family support, and then to minimize this the deterioration of the child's cognitive adaptive function relative to peers. And we also can provide promote the optimal function, individual function in the society, especially for those who has ID. All right, so next. All right, so prevention. So the primary prevention is to prevent ID by addressing the conditions that cause or contribute to ID. So usually we do genetic counseling, especially to, if possible, to avoid any consanguineous marriage. And then we also we can also do appropriate genetic testing and do genetic counseling to be able to inform a decision making. Newborn screening for any metabolic diseases, can also give routine childhood immunization to prevent any preventable disease. Appropriate prenatal care so that you can give optimal care. Prevention of exposure to radiation. Prevention of poisoning accidents. So that, for example, we can ensure that there's adequate folic acid during the pregnancy, and we can also reduce any risk of congenital infection. So secondary, we can treat the underlying condition in order to minimize the risk of impairment in ID. Example is if a child has a hypothyroidism, we can give thyroid hormone replacement, or we can, if any way, we can treat the vision and hearing impairment that may be associated with ID. And we also can manage the seizures or any other coexisting medical disorder. So tertiary is to is to maximize the function and quality of life, which basically the management, which I have already explained on the previous slide, where we try to identify as early as possible to provide any support or services, and also to treat the comorbid or any coexisting condition. I think that's all from me. Any question?
Okay. Just why mental retardation is not used is mainly because of how the word makes the people who have mental retardation feel. Because we are Malaysians, we speak in the school, the kids rarely make fun of each other in English, right? But in America, a lot of times the word retard is used negatively, right? Retard, what else? Moron, imbecile, right? Yeah. Obviously, those are negative words lah. But retard is also used in a negative manner, right? So when you have a negative word, when a word is used in a negative manner, and then you attach it to a medical condition, so a mental retardation, that's a medical condition, isn't it? So there's sort of this implication that you're implying that the people who have this condition are dumb and stupid and retarded. Get what I mean, right? I linked an article in the chat room, right? You can, after this is done, you can just click and just read it lah. It's a very old article lah, but I think it's not informative. It's good to see the point of view of people who have intellectual disabilities, right? It's the same thing with calling. You guys wouldn't know lah. It doesn't matter. It's the same thing with using the word deaf and mute in the US, not in Malaysia, but in the US, even the word deaf and mute also they are starting not to like it because they say it's also giving out a negative connotation lah, right? So that's the reason why mental retardation is not used. It's because retard is used in a negative way. Retarded is also used in a negative way. So when it's associated in a negative way, whoever has that medical condition, it's implied that they are also dumb, stupid, right? So that's why it's not used, basically, right? Okay, next.
So next, let us move on to adolescent health problems. So this is my outline. So introduction, epidemiology, and then we'll talk about range of health problems in adolescents. So actually, what is adolescence? So it is a transition age between children and adult. According to the book, it does not have a specific range, but it defined it as from puberty until 18 years old. But according to Dorland's medical dictionary, it ranging from 11 years old until 19 years old. Then it can also be divided into early, mid, and late adolescence. But it is not according to the years itself, but it is according to biological, psychological, as well as social development of the adolescent. So before we move on to our main topic, so I want to highlight about HATES assessment because this is very important to assess the adolescent. So H is home, and then education or employment, and then now they add another E, which is eating disorder or eating behavior, and then activities, drugs, sexuality, suicide or depression, and last but not least is safety. So I just put it here. I will not explain about it because it is pretty self-explanatory if you read it yourself. So let us move on to epidemiology. So So for the all-cause mortality, it is reducing from 1990 to 2030. All-cause mortality of the adolescent is reducing. And then usually for male, the specific cause of mortality is road traffic accident. But for female, is non-communicable disease, especially neoplasm. And in Malaysia, self-harm and opioid use was low. Next, these are the range of health problems in adolescents. So there are acute illness, such as pneumonia and other infections, and injury also included in the acute illnesses. And then there is chronic illnesses, such as SLE, chronic kidney disease. And then there is somatic symptoms, which I will be explaining later, mental health problems, eating disorders, health risk behaviors, and last but not least is menstruation problems. So let us move on to problems with chronic illnesses. So these are the example of chronic illnesses. So there are asthma, epilepsy, diabetes mellitus, especially type 1 diabetes mellitus, and then cerebral palsy, JIA or juvenile idiopathic arthritis, and sickle cell disease. And their problems are, according to the book, they list 4 causes, which are adherence, biological, psychological, as well as social problems. So adherence, because adolescent tends to want to have social life, so they need to balance between the adherence to the illness or adherence to the medication for the illness with their social life. And usually they tend to have problems with chronic illness with adherence due to lack of knowledge towards the importance of the medication for the chronic illnesses. Next is biological. So chronic illnesses can cause biological problems such as delayed puberty as well as short stature. And next is psychological. So patient tends to have less mature behavior, and adolescent patient tends to have sick role if they have chronic illnesses. And then lack of self-esteem. And last but not least, of course, depression as well as financial problems. Next is social. So usually they tend to have reduced independency, and they also tend to have failure of peer relationship. So as I mentioned just now, they need to balance between the adherence and their social life. And then they also will have problems with absentee especially for the school. Next, somatic symptoms. So somatic symptoms is actually physical symptoms that suggest illnesses or injury, but it cannot be explained by general medical condition, substance abuse or any drugs use, and then cannot be explained by mental disorders. For the example for the somatic symptoms include fatigue, headache, abdominal pain, backache, as well as dizziness. So somatic symptoms is actually common in adolescents. So if adolescent comes with these somatic symptoms, we must exclude organic diseases through history, physical examination, and of course, investigation in some cases. And then these somatic symptoms actually may be precipitated by bully or family problems, mainly parental discord. And then if these somatic symptoms is severe, it may impair the adolescent's quality of life, such as the attendance to the classes and academic performances, as well as social life of the patient. Next is mental health problems. Actually, about 11% of adolescents tend to have mental health problems. And then this table here is the prevalence of the main mental health problems in adolescents. So as you can see, depression about 3 to 5%, anxiety, then we have ADHD, eating disorders, which I will be discussed a little bit later, and then conduct disorders, and then substance misuse disorder. So about 7 to 14% of adolescents will tend to do self-harm. So self-harm ranging from these are the cause why the adolescent tend to self-harm. So first of all is to escape from interpersonal crisis, and it is some of the way to communicate to show distress, and then also suicide. So next is eating disorders. So eating disorders usually is due to dissatisfaction of their perception to their body. And then about 40% of female and 25% of male begin dieting at the age of adolescent. So dieting can be healthy and can be unhealthy. So our concern is that unhealthy part, which are anorexia nervosa and also bulimia nervosa. So because anorexia nervosa usually will have intense fear of gaining weight and intense fear of becoming obese. So they tend to have disturbance of body images. So for example, if the patient is um, already in ideal body weight, ideal BMI, so they tend to uh, control their eating to have lower BMI. So bulimia tends to have less obsessive thoughts and do not have excessive weight loss and more socially inclined. So bulimia, as the difference between bulimia and also anorexia is that bulimia have a binge eating and purging, means that they binge eat and then they purging means vomiting by themselves, not by themselves, not because of diseases, but because they worry that they will have weight gain. So, but bulimia is not really as severe as anorexia. So next, let us talk about health risk behavior, or also known as risk-taking behavior. So this is because adolescent tends to look for pleasure and excitement in new experiences and enjoyable experiences. So they want to feel independent from parent, or it is also as a rebel act. For example, if the adolescent have problems with their parents, they tend to rebel. So they tend to do risk-taking behavior. And then adolescents also tend to have lack of knowledge about the consequences of the health risk behavior. So for example, health risk behavior is smoking, drinking, alcohol drinking, drug abuse, as well as sexual promiscuity. So this usually we ask in social history, right? Next, this health risk behavior usually continue to adult life, unfortunately. So last but not least is menstrual problems. So it actually occurs in about 75% in adults and in female. So the menstrual problems are ranging from delayed onset, amenorrhea, irregularity of the menstrual cycle, heavy flow, as well as dysmenorrhea or pain during menses. The average menarche of the adolescent is around 12.5 years or 12 years, 6 months. And then the menstruation cycle initially longer, with up to 45 days, and usually it becomes regular after 3 years of menarche, which the normal cycle is 25 to 35 days. So, and then the normal duration of menses, I mean the flow, so 7 days or fewer per cycle, and the normal blood flow is six soaked pads or tampons or fewer per day. So I think that's all from me. So these are my references. Basically, I take it from a journal for the epidemiology, and then Nelson textbook, and then illustrated textbook, and also PITS protocol. So is there any question?
Okay, done. Now, just now you were saying that bulimia is not as severe as anorexia. It's actually very difficult for you to say whether bulimia is not as severe as anorexia, because if you have severe bulimia, I mean, it can also cause harm to the patient. Okay, so to the teenagers, so it's not, you can't really blanket statement say like that. Like true, anorexia, you tend to get more of an immediate type of health complications, right? Because of the loss of weight, lack of inadequate electrolytes, you get electrolyte imbalances, you can get all sorts of stuff. Bulimia, people with bulimia tend to maintain a relatively stable weight. It's just that they binge and then they purge, binge and purge, binge and purge, binge and purge. Okay, so next. Any questions, not? Any questions? No, then next one.
Okay. Assalamualaikum warahmatullahi wabarakatuh. Can you hear me? Boleh dengar? Clear ke?
Yes.
Yeah, clear.
My name is Hassan and I will be presenting about the palliative care. Okay. The next. Okay. I will explain the definition from WHO perspective and WHO definition and the principles of palliative care, management of symptoms, and also end of life care. Okay. First, for the definition. Palliative care is an approach that improves the quality of life of patients, either adults or children, and their families who are facing problems with associated with life-threatening illnesses, which means we help both the patients and also their families or their caregivers facing life-threatening or facing death of the patients. It aims to prevent and relieve suffering through early identification, correct assessment, and treatment of pain and other problems, whether it's physical, psychological, or spiritual. So it means a multidisciplinary approach to the patient. We have doctors, we have nurses, and we have also counselors to take part in this palliative care. Okay, next. Okay, the children and adults have different approaches for palliative care, because children's go through different developmental stages, and as their age increase, they become more mature and can understand more about their surroundings and more able to understand their conditions. And also the communication needs are different because For example, units cannot communicate much just by crying and showing distress. So it needs more attention to the younger patients. And next is dependence on adults. As I said before, neonates compared to adolescents have a higher dependency on adults, where every symptoms means yes, high dependency on whether food, shelter, all dependent on the adults. For example, in contrast with adolescents, where they may become more independent and able to take care of themselves, going to the toilet, however, sometimes adolescent patient may also want to be dependent, to be like a kid and because they feel like death is approaching, so wants to have more support from their families. And this palliative care this on children is involves more on the family and also the patient, because if a death, a life-threatening illnesses on the child has more impact on their parents, because their parents have more emotional bond with the children and have more emotional distress when where they find out these have life-threatening illnesses. And it can also impact the financial situations of their families, because in the pediatric ward, one of the caregivers need to be there to take care of the child. So that means one less person to find money for their financial situation. Okay, next is types of health conditions, because type of health conditions between pediatrics and adults are different, because some more rare conditions, congenital conditions such as trisomy 13 and 21 is more commonly seen in children and less in adults, because their life expectancy is less. For example, trisomy 13, trisomy 18, Edwards syndrome has 50% chance of to life expectancy for after 1 year, so less in adults. And then for pediatric formulations and dosing of essential medicines is also different, because medications, for example, oral medications in such as pills, the baby may not be able to swallow, so we need to crush and to blend in the water so that the baby children can eat easily. And also the dosing is also different, because it depends more on weight to dose ratio. Compared to adults, it is more significant. The weight plays more significant role. And also degree of difficulty in clinical decision making, because symptoms of the pediatrics sometimes is hard to tell. Kan sakitnya macam mana, tanya budak susah dia nak jawab. So, sorry, English. Okay. Next is clinical environment. The clinical environment for the children needs to be more cheerful, more more engaging, so that the children are not becomes distressed. It become there needs to be colorful room. There needs to be someone there because children fears isolation, so there needs to be people in the room with the children. Okay, next. Okay, These are some examples of populations that needs pediatric palliative care. For example, children with acute life-threatening conditions, which recovery may or may not be possible, or it can be also chronic, and conditions which are progressive and life-threatening, but where there are no cure treatment available. Children with severe neurologic conditions which are not progressive but may lead to deterioration and health and death. For example, spastic quadriplegia, spina bifida, and also neonates who are severely premature or have severe congenital anomalies, anencephaly, congenital diaphragmatic hernia, trisomy 13 or 18. These have low low prognosis. And also family members of a fetus or child who dies unexpectedly. This also need palliative care because we need to counsel the family members on the conditions of the patients, and also what do they expect. Is there a cure, or is there how do the child may future? Can they grow old or something like that? And for example, any fetal demise or overwhelming sepsis in a previously healthy child, trauma for motor vehicle accidents, we need to counsel the parents. Okay. Next. Okay. Okay. Of the previous conditions, there can be categorized into 4, which we manage the treatment based on the aim of the treatment, which means for the first category is curative, to cure the patient. For example, patient with cancer, advanced cancer, we can give radiotherapy, chemotherapy. There is a chance of cure, but it may or may not, depends on the staging. And the second is there is intensive long-term treatment at prolonging life. Means we have aim to maintain the quality of life as long as possible. And the third type is treatment that is exclusively palliative after a diagnosis of condition, progressive condition is made. For means which we try to make the patient feel comfortable even though we cannot cure the conditions. For example, there are symptomatic management. And last is treatments that are available for severe non-progressive disability, patients who are vulnerable to health conditions. Means we prevent the patient's condition to become worsened. We do not prevent any complications, for example, bed sores by foam mattress, like that. Okay, these are the categories.
Jap. Kenapa cakap dengan tulis lain? Treatments available because
sorry.
You said treatments not treating the
sorry.
Treatments available for, okay, yang nombor 4 tu, treatments are available for severe non-progressive disability in patients who are vulnerable to health conditions.
Yes.
Meaning you try to prevent bed sores. You said don't prevent bed sores. Obviously, you're going to prevent bed sores, right?
Yes.
If the child is spastic quadriplegia, gets bed sores, and the bed sores get infected, then they can get septicemia, true?
Yes.
Right? You do positioning for them, isn't it? You do chest physio for them, isn't it? To reduce the chances of them developing orthostatic pneumonia, because they can die from orthostatic pneumonia, but it's preventable with proper physio, chest physio, with positioning of the patient, isn't it? Proper suctioning if it's the very, very severe type of CP, isn't it? Right?
Yes.
So curative treatment is possible but may not succeed is number 1, true. And any advanced cancers, right? Sometimes there's treatment available, but sometimes you have to weigh whether the possibility of the child recovering versus all the side effects that the child may go through, right? So if the possibility of a child recovering is very, 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 very low, and the child might not have a good quality of life by going through the treatments, chemotherapy, radiotherapy is no joke, isn't it? Right? So sometimes the discussion of palliative care might come up, right? Treatment that is exclusively palliative after diagnosis. So Edward syndrome, you know that they are gonna die anyway, right?
Yes.
And carefully, you know they're gonna die anyway, right? There is intensive long-term treatment aimed at prolonging life. So these are children who, with treatment, they can have a relatively good quality of life, lah, right? So cystic fibrosis, they can live until their adulthood, isn't it? But with proper treatment, lah. So the last one will be that CP thing as well. Okay?
Okay.
If you find yourself nervous, you just stop for a while and take a deep breath.
Okay.
Okay? If you said the wrong thing, immediately correct yourself, because if you're saying the wrong thing, and then your friends are going to learn the wrong thing from you. It's harder to correct a mistake than it is to learn it correctly from the first time. Understand not?
Understand.
Okay.
Sorry. Okay.
Some more, this is not face to face, you know. This one I'm not even looking. You guys are not even looking at my face.
Okay. Next is the principles of integrated palliative care. Okay. For integrated means there are to many disciplines joined together to in this palliative care. The principles are we respect the dignity of the patients and their families, which means we explain the conditions to the patients and we explain what are the methods available and what's the patient and the parents' goal of treatment, whether what is available to opt for chemotherapy or not, such things like that. Okay. Next is access to comprehensive and compassionate palliative care, which in palliative therapy there are more focus is different from the at ward, for example, in the just outside. They are more comprehensive because more on focus on pain management, relieving of symptoms. However, we still use we still use multidisciplinary approach and use of interdisciplinary resources. We can contact counselors and also the palliative care physicians for when the patient is enrolled in palliative care. We can all in the first principle is acknowledgement and support of provisions for caregivers. We acknowledge the support to the caregivers, the importance of the caregivers to the patients, and we also acknowledge the emotional and psychological impact of the patient's conditions to the caregivers. So we counsel the parents. We try to give any modalities to alleviate the burden on the parents. And the final one is commitment to quality improvement of palliative care through research and education. Which means the hospital regularly to monitor the patient's quality of care, which we use to improve further modalities, further improvement for the palliative care. Which means symptomatic, is this is one modality better than the others, and what is the efficacy, things like that. Next. Okay. Hospice care. Hospice care is treatment program for the end of life, for the preparation of end of life. We provide the range of palliative care services by interdisciplinary team. However, hospice care is difference between hospice care and palliative care is palliative care starts from the diagnosis, and while hospice care starts after the treatment, when the prognosis, when the available treatment modalities are not, we are not likely to expect the patients to have to have good prognosis. Okay.
Basically, care for the people who you think are going to die very, 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 very soon.
Yes. Yes.
Okay.
Yes. Okay. Those who can receive hospice services are those who have a prognosis of death within 6 months, and the cessation of curative efforts for children, and the curative efforts may continue while higher level of coordinated end of life services may be applied. Okay. These are those who can receive. Okay. Bereavement. Bereavement is, or mourning, is a process of psychological and spiritual accommodation of death, which means a period to get acceptance, a period of grieving period, of intense grief, where the parents of the patient undergo to accept the death of their children. And grief is an emotional response caused by a loss, including pain, distress, and physical and emotional suffering caused by that loss. It is a particularly difficult issue for patients whether to talk with their child about the child's imminent death. This is some parents are more likely to regret not talking to the child about death than having done so. To get the last words of to spend their moments with their child, to whether or not to tell their child whether that he's going to die or not. There's an issue for the parents. So we counsel the parents on the issue. Okay, and how to tell the children about dying and death. However, it depends on the cognitive stages of the patient. Next, according to Piaget, there are four stages. There are stages of Piaget theory. There are first sensorimotor stage, where for very young children up to 2 years of age, where the children are unable to comprehend death, but they just treat death as separation from the others. Children with separation, when are separated, they are more prone to protesting and difficulty to attachment, to become attached to other adults. It becomes through a tantrum, and this difficulty depends on the availability of other nurturing people whom the child have good previous attachment. So if the child has have a bond with one of the parents, please do not separate them. Okay, this one of the questions which the child may ask during about their death. For example, "Mommy, don't cry." They have limited understanding of the events and may have sense they think something is wrong. And how we manage this? By optimizing the comfort, consistency, put family persons or objects with the children, use soothing words, and show love to the child. After next stages is pre-operational, which is children from 3 to 5 years of age. They still have trouble to understand the meaning of illness and permanence of death. They understand death, but unable to comprehend that the death is permanent. Their language skills at this age make understanding their moods and behavior difficult, because even though they can to say several sentences, they still cannot form abstract or logical thinking, and they may think that is like a punishment, because, for example, and all the siblings, when they are jealous of their younger siblings' attention, they think they feel guilty, because these are the stages where the children might feel guilty. So they think death is a punishment for him because of that intention. And they can also feel overwhelmed when confronted with strong emotional reactions of their parents. So so a calm and calm approach to the calm and relaxing approach is better than shouting between parents. Next is, for example, I did something, they felt guilt, so I did something bad, so I will die, like that. So we assure the patient's illness that are not the patient's fault, and use simple language and use books or to promote questions and answers. Okay, next is the late operational to concrete operational between 6 to 11 years old, where the finality of death gradually becomes understood. The magical thinking gives way to need to give detailed information and to regain a sense of control, which their imaginations go wild to justify or to intellectualize their the finality of death. And in this range, have strong need to control their emotions by compartmentalizing and intellectualizing. So next. So they will ask about how will I die? Will it hurt? Is it scary? So the children becomes more able to reason logically, and however still have abstract reasoning. They understand death is permanent, and but may not able to accept death or to himself or anyone he knows, but still realize that everyone he knows will die. In this patient, we must be honest and provide specific details if they are requested, and we give help and support that they need for control, and encourage their participation in decision making. So to make them feel more confident and in control. Next is formal operation, which is older than 12 years of age, where death becomes a reality, which is universal and irreversible. Adolescents handle death issues at the abstract or philosophical level and can be realistic. However, they may avoid emotional expression and information, instead relying on anger and disdain. Their wishes, hopes, and fears should be attended to and respected too. Okay, next. Okay, they become able to think what are the effects of his death to their surroundings. For example, if I'm afraid if I die, my mom will just break down. They understand death is not reversible, need to be constant reassurance. So we reinforce the child's self-esteem and self-worth, allow for privacy, independence, and access to friends and peers. And we tolerate we tolerate what you are feeling is true. We do not deny what the children's feelings, so that their self-esteem is, I can't imagine how you are feeling, but you must be an incredible job. I wonder how I can help, things like that. Next. Okay, that's the how we approach the child to explain about that. Okay, next is the elements for palliative care, which are first is pain management. The second is expertise with feeding and nutritional issues. The third is management of symptoms, such as management of nausea and vomiting, constipation, dyspnea, fatigue, delirium, and also agitation. Okay, next, because pain is the most common complaint of the children. We must identify the pain and assess its severity by using a graphical pain chart for children, and we also treatment to eliminate or reduce pain, whether to give patient analgesia. We use analgesic, WHO analgesic ladder to approach. We give non-opioids, then after that then we give opioid if it is still pain is unmanageable. We avoid any unnecessary or painful procedures, which is, for example, any branular incision, thrombophlebite. We avoid inflicting pain on the patient, which means any painful procedures we avoid. And then we give adequate doses of analgesics to be administered by the clock, which means we do not give the analgesia by PRN. We give regularly. We, for example, 6 hourly or 8 hourly to analgesia, and we give sufficient dose for an appropriate pharmacological formulation. We give sufficient dose is when the pain is gone, and appropriate pharmacological formulation is, for example, in baby, in young children, we need to crush the pills and give it with water, like that. And appropriate opioid dose is the dose that effectively release pain. Next. This is WHO analgesic radar for pediatrics. If mild pain, we give no opioids. If pain increase or persist, we give strong opioid. For moderate and severe pain, we can also give non-opioid together with the strong opioid, also adjuvant. And to avoid constipation, we also give prophylactic laxative. Okay, the age of opioid, non-opioid we give is for less than 3 months. We give ibuprofen or paracetamol, and if more than 3 months, we give ibuprofen or paracetamol. If less than 3 months, only give paracetamol. And strong opioids such as morphine, fentanyl, oxycodone, hydromorphine, buprenorphine, and the adjuvants are antidepressant, convulsant. We can see in the slide. Okay, but however, we cannot combine the drugs in the same class because of the effects may overlap, and we are unable to. Okay, and we time the doses based on the drug half-life. Do not wait for the pain to recur. Okay, next. Okay. Expertise with feeding and nutritional status. We provision the enteral and parenteral nutrition based on the patient's condition. We identify which interventions which may improve anorexia or cachexia for malnourished patients or patients with cancer. And we review potential adverse effect of enteral nutrition. For example, in patients with any lactose intolerance, for example. And we also review that children can live comfortably for a long period of time with minimal fluids and nutrition. Okay. Next is this is principles of management of symptoms. First, we recognize and assess the treatments regularly by assessing the child's physiological, social, spiritual, and physical symptoms. And the core principles of symptoms management is first, treat underlying cause. Second is drug combination of drug, behavioral, physical, and supportive therapy. If the symptoms are persistent, we treat with regular interval medications. If symptoms are severe and uncontrolled, should be regarded as medical emergency, which require active intervention. And we must avoid any inappropriately invasive or painful route of drug administration, which means we avoid IV line and we give oral route. And side effect on medication must be anticipated and actively treated. Next, for example, dyspnea, the causes are pulmonary disease or airway obstruction or heart failure. So we give suction, comfortable loose clothing, fan to cool, and also behavioral strategies, including teach the patient how to breathe and which position to breathe. For example, in COVID patient to lie prone to allow better breathing, things like that. Next is nausea and vomiting, which may be caused due to radiotherapy or chemotherapy. Can also caused by opioids and acid. So if patients are on medications, we need to review the prescriptions and also prevent constipation if we give prevention of constipation, and also give antiemetic medications, and also management of electrolyte and abnormalities which are caused by the frequent vomiting. So we need to correct the electrolyte. Next is constipation. Causes of constipation are immobility, got for example bedbound or muscle weakness, or poor oral intake, or any medications. So we promote increase in fluid intake, also fiber in their diets, and also give antiemetic and also laxative to allow better bowel movement. Next. Okay, next is fatigue. Fatigue, there are many causes of fatigue. For example, anemia, infection, pain, impaired nutrition, because of sleep disturbance, depression, anxiety. Okay, so if the patient have depression, we treat give treatment and encourage gentle, regular exercise such as physio, such as yoga. And if the patient have anemia, we need to give treatment. With iron deficiency anemia, we give iron. And if if it is needed, we can give psychostimulants, which is methylphenidate, but it depends on the patient's condition. Next. Okay, next is end of life care. Okay, end of life care is the management of end of life symptoms. Okay, we have to give ongoing preparation and support for the patients to give patients their most comfortable to give better quality of life. And we can ask the patient whether to select a preferred location of death, whether in the hospital or at home. For example, some parents might opt to spend their last moments to with their child at home together with their whole family. So can opt the care. Next is discussion on autopsy or organ and tissue donation. This is relevant in cases where with in rare diseases such as genetic abnormalities. We need to counsel the parents if there is it is allowed for further to let the parents understand better about the children's diseases and why the condition. And we also provide bereavement support and counseling to the family after death, and also we give counselor group therapy. For example, there are cancer support groups which families of cancer patients go together and tell their experiences on how to grieve, how to accept the death of their children. Okay, that's the end of my presentation. Any questions?
Hassan, lain kali kalau present, either if you know you're not good at presenting, if you know you have a problem with presenting in English, write down a script and practice, because that's the only way you can get better. Because presenting is not just presenting during presentations, it's also presenting during rounds. Okay, so presenting during case studies, during grand ward rounds once you are working later. It's ready, you guys already final year kan?
Yes.
So if you are the type who gets nervous, then write down a script and practice reading from the script first. At least if you panic, there's a script for you to follow. Okay, now if everybody look at the chat, right, there's 2 videos linked over there. Okay, both are about end of life for kids. Basically, both kids have SMA, spinal muscular atrophy, right? The first one, the one from CNN, is where the child has decided herself also to basically when the time comes to just choose to not suffer, right? The other one is more of the parents. It's a Singapore one, more of the parents deciding for the child, but the child also knows what's going on. Now, whether to discuss death with the child or not depends on how mature the child is. Not really chronological age, because you can be old, but still can be mentally immature, right? You can be young, but mature in terms of thinking, right? So if you look at the one from CNN, the child is very much more aware and very much more developed in terms of she knowing what she's going through, right? So I think the first video is only 5 minutes. The second video is slightly longer, but the first, if you can watch, at least watch the first video, right? It's only 5 minutes of your time. That's like two music videos, right? 1.5 music videos actually. Okay, so any questions or not? No?
Doctor, I
Yeah.
have a question. For palliative care, do we need parents' permission? And if they refuse, do we have to report any to any authorities or just let it be?
Excuse me. What do you mean by you have to ask for parents' permission?
For the main treatment, if the parents refuse for the main therapy like chemotherapy.
Oh, no. Okay. Wait. There's two issues here. You be very, very clear. Number one is, what do you mean by do you need parents' permission? As in, the child can still be treated with a high possibility of recovery, but the parents refuse treatment, or the child chance of recovery is very, very low, but then the parents insist want to go on with treatment, or the child chance of recovery is very low, but you are discussing about, but there's no but. There's only three situations you're talking about. One, the child has a curable disease, right? Has a disease which is potentially curable. Okay, high possibility of being curable, but parents refuse treatment. Okay, that's one, right? Another one would be if the child has a low possibility of being cured, but parents insist on continuing with treatment, right? The third possibility is child has low possibility of getting cured and parents agree that to discontinue treatment. So which one are you talking about now?
Number three, the third question, the third condition.
The third question, I think obviously anything you offer to the child needs parental consent, right?
Yes.
True or not? So that's the basic thing in Malaysia, at least. Anything that you do to a child needs parental consent, right? That's the basic premise in Malaysia. US, yes, you can ask for, what's the word for it? The child can ask for, what's the word? When I think of the word, then
Emancipation.
Yeah, emancipation if they're old enough. But in Malaysia, generally, whatever you do to a child needs parental consent. Number two, if you've already exhausted all forms of therapy, right, and the likelihood of the child getting better is very, very low, what type of parents do you think will actually say no to treatment that will make the child feel more comfortable? You get what I mean?
Selfish parents.
You would think so, isn't it?
Save money, save time. Like, I'm just thinking about that.
Okay.
For the first condition, if the parents refuse the main treatment, then do we still offer for palliative treatment?
We in Malaysia, we cannot force somebody to take treatment, basically, isn't it?
Yeah.
Right. In overseas, yes, there are provisions in the law where if the child has potentially treatable disease, if the parents refuse for whatever reasons, there are legal channels they can go through where the social services will kind of take over the legal rights of the parents to decide for the child, but that one has to go through courts, right? But that's overseas. That's not in Malaysia.
Okay.
A lot of times here you cannot if you think of it logically also, apart from the police getting involved, the courts getting involved, right? How are you going to force parents to bring the child to the hospital? Also cannot, isn't it? But overseas, yes, there are legal channels in which you can go into to get the child to get treatment, right? But Malaysia, no.
All right. Thank you, Doctor.
Anything else? Ada apa-apa lagi tak? Tak ada. Ada tak ada? Tak ada, tak ada. Kalau tak ada, jap. Tak ada kelas dah kan dengan kamu semua? Ada lagi ke tak ada? Dia tak ada kan? Ada kelas tak lepas ni? Ke you're getting weekly schedules? In your schedule, do I have any other classes scheduled?
Sekejap doktor, tengah check.
Ke you're getting the weekly schedules because I'm just getting weekly schedules. Right.
No, we already got full schedule.
Do I have any other?
Wait,
Ada lagi ke tak?
tak ada doktor.
Tak ada. Okay. So
Tak
then, bye-bye.
Alright, okay.
Have
Thank
fun.
you doktor.
Watch the 5-minute video. You don't watch the 26 video, never mind. You watch the 5-minute video, please.
Alright, okay. Thank you
There
doktor.
is like 2 Blackpink videos or 2 BTS videos. That's it. One
BTS.
BTS videos are long, isn't it? Some of them is like
Yes.
5. Who is waking up? Who is gonna be stuck to YouTube on Friday? Friday kan? I think so. Friday kan? Come back.
Doctor, are you an army?
No, I'm not. But I know what's going on.
Okay.
I know what's going on. I'm not that blur. Okay. Bye.
All right. Thank you, doctor.
Thank you doktor.
Thank you, Doctor.
Thank you, Doctor.